which population is harder to evaluate, treat, get results with? Either elite athletes, like professional athletes, Division I athletes, Olympic athletes, or general population, work comp, weekend warrior, overuse injury, total knee replacement recovery, that kind of stuff. So interesting thing is you guys came in at almost a dead heat, and we had about 130 of you reply. So rather than shoot a 1-minute video here, what I'm gonna do is shoot a full video breaking things down on the whiteboard. So come follow me. So we're gonna put this on the whiteboard, and we're gonna break down evaluation, treatment, patient education, exercise progression, all of this stuff, so you can see what my opinion is on each one of these points, and we'll figure out who's the harder population to get results with. At the end of this, I'm gonna show you the one key that makes that population easy to deal with. All right, so let's look at this. So, get a marker here. All right, so we're gonna break this down one by one. So, elite athlete, general population, here's what we're going to score. So, evaluation, which one of these populations is harder to evaluate? Think about that as they come, as they're giving you their report. Which one is harder? So, general population, probably not the most in tune with their body. Elite athlete, very in tune with their body. So, getting history and subjective, probably easier to get that from the general population. So we're gonna say subjective part of the evaluation, harder with general population. Now, objective, watching them move, scoring them, range of motion, all that kind of stuff. The thing to keep in mind here is the reason why an elite athlete is because they compensate really, really, really well, which is going to make them harder to evaluate. But if you're evaluating neuromuscular function and getting down to the root cause, we're gonna put that more in the treatment because it's baked into the treatment. So what I'm going to say, in my opinion, the harder population to evaluate as far as subjective reporting and getting good information there is going to be your general population, okay? So now we get to treatment. So as I was saying, elite athletes are elite athletes because they compensate better than anybody else. You are not going to be able to use the eyeball test to watch an elite athlete move and say, oh, I see you do this, that's because of X, Y, or Z. Not gonna happen. If you're doing that, then you're missing the whole point. You're never going to get to the root cause. So this is baked into our treatment because if we're assessing neuromuscular function, we're actually breaking them down muscle by muscle. And when we do that, when we find neuromuscular inhibition, then we should immediately be reversing the neuromuscular inhibition. So your assessment, your analytical assessment, point by point, muscle by muscle assessment gets right into your treatment. So general population is pretty easy with this. A lot of them are gonna have a lot of things going on all over the place. When you watch them move on a functional screen, you can see gross issues going on. So they are easier to evaluate and then get right into treat. Your elite athlete is going to be harder. And as you go through your treatment, if you miss one thing with them, they will figure out how to compensate around that one thing, and they'll come back with either the same problem they had on the first visit, or they've compensated it differently to figure out a way around it, and now they've got a new problem that you're dealing with. So unless you treat the root cause of each one of those specific muscles that have issues, then your biomechanics are still off, your functional movements are still off, they're gonna compensate with whatever you give them for exercise, and they're gonna continue to have problems. So as far as treatment, elite athletes are harder to treat, okay? Exercise prescription. So elite athletes, very versed in exercise. Probably not a lot of patient education going on here. If I have an elite athlete come in and I say, I want you to do A skips, B skips, and C skips, they probably know what those are. If I get to the point in the progression where I'm doing A skips and B skips and C skips with the general population, I'm spending a lot of time with patient education because they don't have exposure to that kind of an exercise program. So as far as progressing or prescribing exercise, your elite athlete is much easier, harder with general population. Okay, patient education. Which one of these populations do you think is harder to educate? So when my patient populations come in, either one of these two, I know in the back of my head when I ask them there's really only three to four important questions that I'm asking them in their subjective. And we've talked about this in videos on here before. One of the most important questions is, what have you tried to do up until now to decrease pain, increase range of motion, increase strength, whatever it is? And both of these populations get terrible advice from all over the place. So elite athletes are getting terrible advice from their coaches, from their personal trainers, from their strength coaches that are still stuck in the broken system, that are still doing stuff from the 80s, that are still stretching and still pushing foam rolling and still allowing them to do a Theragun. And the big problem with this population is when they see other elite athletes doing garbage, they think that's the right thing because elite athletes are doing that, so I need to roll and stretch and Theragun, and why aren't we doing needling and where's the K-tape? So very hard to break them of that. So there's a lot of patient education going on here, especially if you're dealing with an elite athlete population that is gymnastics, dance, something like that, where they think they need flexibility, which they do not. They need motion plus strength plus stability throughout the full range of motion, which is mostrability. So when we educate them to stop working on being flexible, because flexible is what gets them hurt and gets them in our office, we have to replace that with mostrability. For some people, especially dancers and gymnasts, that takes a while to get in their head with demonstrations. Here's what happens when you do this, we demonstrate that, so then it's easier to get through their head. So you're probably thinking, okay, patient education, harder for elite athlete. No, it's just as hard for general population, because what do? They spend time on WebMD, and they already went to their physician and got x-rays and MRIs and think they have disc problems and think that they should be stretching, because what did the physician do? They gave them the handout for the magic 4 exercises and 5 stretches for plantar fasciitis, or the 4 exercises and 5 stretches for shoulder impingement, whatever it is. So these people are being educated by their peers. These people are being educated by people that they think are the medical experts, but unfortunately, physicians, surgeons, WebMD, whoever else they're getting information from are usually just as bad as where these guys are getting information from. So patient education is just as hard on both sides. So we're gonna give that a tie. All right, progression from first visit to second visit to fifth visit to getting them back to play. Which one of these is harder? General population, you're going to see immediate huge results because they have a lot of gross big problems that are easy to fix on that first visit. So when they come back for their second visit, they might have been coming in for low back pain, plantar fasciitis, and intermittent headaches. And you treated all those things on the first visit because you should be treating every single problem on every single visit. And if you do that, you got really big results. They might come in for their second visit and say, I feel fantastic. I do my exercises 2, maybe 3 times a day. I'm already back to doing what I'm doing. Fantastic. Now, when they come back for their second visit, that's when they're going to be more like the elite athlete. And now we've got to drill down further because we have less gross big things to work on and a lot more smaller individual tweaks that we need to work on. So does that make this population harder to progress or easier to progress? Let's look at these guys. So progression for these guys. What we need to understand here is these guys are going to be extremely easy to get things to reverse. So when we're reversing inhibition, these guys are extremely sensitive. They will reverse inhibition really fast. Now, how much will they hold on to in between visits? That's the key. Who cares if they do better on their functional screen and they have less symptoms 5 minutes or like half an hour into their first visit? My question is, how many of those symptoms come back an hour into training? That's the important thing. It's not what they feel like when they leave your clinic. It's what they feel like and how they function at the end of practice and end of competition. So these people, as we said here, compensate like crazy. So we have to continuously give them things to help break down the compensation and help them use what we refacilitated. So good thing is they're pretty compliant with what we give them, okay? Because they're motivated to get back to play. And we didn't have to spend a whole bunch of time teaching them how to do their exercises. So they do really well at that stuff. So once again, where are we gonna put this X for progression? I would put this X over here, and that is because we have to progress. And a lot of these people, especially if you're dealing with contact sport athletes, they are resisting other things crashing into them, whereas these people are usually trying to move better after they sit in a chair, or reach up and put something on a shelf after they've spent the weekend painting or something like that. So a lot more resistance of things hitting them, hitting other things, pulling other things. So that's going to lead our our exercise progression is going to change probably every single time they come in. So we're going to give them a core group of things to work on, but as we progress, we're going to progress faster. And we also have to keep in mind muscle, not just gross muscle strength or facilitation, but facilitation in combination with muscle endurance. So if these people are feeling fantastic at the beginning of practice, but they're falling apart halfway through practice, they're falling back on their compensations. So we have to reassess this stuff every time they come in, figure out how long it's taking them to fatigue, and then that's the big factor that comes into here. We don't have to worry about fatigue a whole bunch with this population. We don't have to worry about resisting forces crashing into them. We have to worry about that with this population. So even though this population comes in for their second or third visit and says, I feel fantastic, I'm getting through practice with little to no problem, my range of motion feels good, that doesn't mean that they are ready to go. That just means that they feel like things are doing well. We still need to break them down and make sure they're not compensating around. So notice how this keeps on coming back to neuromuscular function, compensation, and when we get down here, muscle endurance. So if you are not programming muscle endurance factors into their home program and what they're doing when they go back to their strength coach or their speed coach or their regular practice coach, these people will look good for 2 or 3 visits and then all of a sudden fall apart. And then you're like, well, what happened? What did they do wrong? They didn't do anything wrong. You didn't keep on drilling down to make sure where their compensation pattern is, and you didn't take in muscle endurance into their exercise prescription progression. So now let's figure out who of these populations is harder to deal with and how to make it easy to deal with both of them. So if we add this up, we've got 3 and we've got 3, which is about where you guys came in on the poll. So when I posted the poll on Instagram, I think it was like 47% and 53%, okay? So these populations are the same. This is my take-home message for you. It doesn't matter who walks into your clinic unless you are treating dogs and horses and cats or maybe aliens. You are treating human beings, and human beings have human physiology. It doesn't matter if they are here or if they are here. Yes, there are certain factors that we went through that are going to differ, but when you get down to root cause, the root cause of these people's problems is the exact same as these people's problems. So when I see both populations, I don't ever change my thinking. My thought process remains the same. My treatment strategies remain the same. I do the same thing with both populations and get phenomenal results because it's human physiology that should be driving your thinking. Okay? When you get them away from doing the things that are actually making them worse, that they think help them out. Once I tell patients, stop stretching, stop getting a massage, stop going to the chiropractor, stop using the foam roller, stop using the Theragun, get rid of your orthotics, stop doing the corrective exercises that are actually making you worse. Once we get rid of that, you've fixed 50% of their problem in both populations. So that's why this is huge. And as you see, it's a limiting factor for both populations. So if I take those things away, I've already fixed 50% of the problems. Now it's up to me to fix the other 50% by getting through this stuff. And as you can see, it's once again pretty equal. So if you have a thought process that gets you down to root cause by understanding neuromuscular function, that gets you away from the garbage that they've been doing before, that gets you to the root cause, that gets you to what's causing them to compensate, and then you're programming that with the same thing in mind. So as you go through your evaluation, you see things happen. The eyeball test takes you somewhere, but it doesn't prove anything. You put them on the table. Now you break them down muscle by muscle to see what is going on neuromuscularly. You fix that. You get them back off the table, you redo the screen and the eyeball test, and what do you know? They move way better, they have less symptoms, they have better strength. That tells you that you're on the right road. That doesn't tell you that you fixed anything. That means you're on the right road. You still have to get to this and this to start fixing things long term. And if doesn't matter which one of these populations you're seeing, it's the same. So don't think that just because you see general population things and you have a Division I athlete walk into your clinic that you have to change your thought process. Now, if you're using the broken medical model, what you learned in PT school, yes, you have to change your thought process, but you had to change your thought process for these people, and you haven't done that. That's why they're coming in 2 to 3 times a week for 6 to 8 weeks for symptom modification, and they still feel like crap and they still not going back to what they were doing. So that's the difference between old school conventional thought process that never gets you here and using the 180 system thought process that gets you to root cause and lets you check the boxes and move through and make both of these populations extremely easy to deal with and to get immediate and lasting results. So if you got questions, post your questions below. And if you got questions about what it takes to get here, to get this thought process, DM me and let me know, and I'll let you know how I can get you here in 4 months to make every single patient that walks through your clinic easy to deal with.